Hi, everybody. This is Dr. McLaughlin again, and moving along in the discussion on congenital urinary incontinence, specifically ectopic ureters in dogs, I'd like to talk just a little bit about the anatomical types of ectopic ureters, extramural and intramural, and also the additional anatomical abnormalities that can occur. As you look at the slides, the pictures on the front of the slide, on the top, you will notice an image, an endoscopic image taken within the vestibule of the dog. So the scope is just beyond the vulvar lips. This is very normal anatomy. You see on the top with a white arrow, the opening to the cranial vaginal vault. You see the mucosa on the inside. So this would be the region that you would be passing a pipette or a scope to inseminate a female dog. The small black arrow along the edge indicates this area called the cingulum, and that's the edge of the cranial vaginal vault. The dark arrow below is the opening to the external urethral orifice. Notice how small and well defined this is in a normal dog. Now compare that to the image that you see just below, and you see that the opening to the cranial vaginal vault is rather irregular and it has a band or a septum across the middle with the denotation of PMR, which stands for paramesonephric remnant. Please remember that the presence of a septum or a paramesonephric remnant is not pathognomonic for ectopic ureters, although we see it in almost every patient that has one. It's more pathognomonic that there's a congenital abnormality going on. Below, you notice that the opening to the external urethral orifice is rather large and irregular, and you can see that the yellow arrow is pointing to a distally displaced ectopic ureteral orifice that's all the way at the distal end of the urethra. Okay, when we talk about the types of ectopic ureters, way back when I was a student, I remember the surgeon walking into the lecture hall and saying, "Hey, we're going to talk about ectopic ureters, and it's just a plumbing issue. Mother Nature forgot to attach the ureter to the bladder, and so it opens below the bladder, and then the dog's incontinent. This should be a quick fix. You just put the ureter back in the bladder." And I thought that that was all very cool, but now many years later, I've learned there's really a lot more to it. So an extramural ectopic ureter is in fact a ureter that travels through the retroperitoneal space in the lateral ligament. As it comes out, it should attach to the dorsolateral surface of the bladder and open, but in fact, it does totally bypass the bladder as depicted in these pictures and attaches to the urinary or reproductive tract somewhere below the bladder neck. So in the urethra, the vagina, uterus, vestibule. This form of ectopic ureter, which was the only thing I knew when I was in vet school, is actually the most uncommon form that we see. So Dr. Reichler from Switzerland, she did report 24% in the dogs she saw, which is a way higher number than I think we see here in the United States. And I don't know whether that's related to the population or breeds of dogs that she sees, but I would say literally in the hundreds of dogs that I've looked at over the years, it would be way less than 5%. It may be more common in cats than in dogs. So again, when we use an endoscope to look up through the urethra into the bladder, we see an opening of a displaced ureter, as you see here. That's great, but that doesn't tell us exactly that it's ectopic. We're only seeing the opening there. As you look at the slide on the right, we have the bladder pulled up and we have the exposed urethra that are marked. And then on the right-hand side of the slide, within the white arrows, you see the translucent ureter coming down, and it passes right alongside the bladder neck and the urethra. And this is an extramural ectopic ureter. This ureter is bigger than normal. We would expect a normal dog ureter to be about 3 millimeters. Now let's compare that to the more common form of ectopic ureters that we now recognize, and those are the intramural form. In this situation, the ureter travels through the retroperitoneal space and exits within the lateral ligament, and it actually attaches to the bladder in what appears to be a very normal position on the dorsolateral surface of the bladder. The problem with this is if you were in, say, doing an abdominal explorer, spaying a dog, and you flip the bladder up and you're looking at the anatomy and structure of the bladder, this would look like a very normal situation. The problem here is that the ureter attaches normally, it just fails as it transverses the wall to go completely through the mucosa and submucosa and open at the tip of the trigone. So instead, it goes through the wall and stays below the mucosa, submucosa, and tunnels or travels distally and opens in a distal site. In this picture, you can see the ureter coming through the lateral ligament. Once again, this ureter is quite large and it's attaching in a very normal position on that dorsolateral surface at the white arrow. If I have the bladder exposed in surgery and I've opened the ventral surface of the bladder into the urethra, we can actually find the opening of this intramural ureter. And you see I have a red rubber urinary catheter slid up through the opening and it's tunneling underneath the mucosa. It's kind of translucent, we can see it, all the way up to where my thumb forceps are, which is the point where it crosses over through the bladder wall, right where the white arrow is. So this ureter is actually tunneling quite a distance. Tim Voigt, our artist, depicted a really nice image for me. And we see in B, this is a fairly normal ureteral orifice at the tip of the trigone, compared to A, where the ureter comes at the normal position, yet tunnels distally and opens within the urethra. Again, we have found that intramural ureters are far more common. We also have found that if you look very critically of both ureters, most of the time they are bilaterally displaced. I think very frequently they are displaced at different levels. So once again, this dog, his apex of his bladder is up. We have the bladder open on the ventral surface and we've opened down into the urethra. And you see the two red rubber catheters. This one is probably midway down the urethra and it's tunneling up underneath through the bladder neck and trigone. And the other one is not, it doesn't have quite as long of a tunnel, but it certainly is not in the normal position at the tip of the trigone. So if we demarcate approximately where the region of the bladder junctions with the urethra, the vesicourethral junction, VUJ, and we consider the formation of the trigone as a triangular area, the opening of these ureters should be way up in each corner of the trigone. So you can see that both of these are displaced just at different levels. Here's some crazy pictures that we see now that we have so much imaging that we can do and endoscopically. So when we're looking with magnification in a clear fluid environment, the whole top row are pictures within the vestibule, just through the vulvar lips. And again, we notice that the opening to the cranial vaginal vault is almost always displaced with a septum, that paramesonephric remnant. We can see some crazy openings of these of these ectopic ureters, and this is an intramural ureter in the slide on the left here. Note that the external urethral orifice is kind of dilated and elongated. It's not small. In the middle picture, we see a smaller opening for a ureter right at the base of that septum. And then the one on the right is a very classic image that we see in many Labrador puppies that are incontinent, where both of their ureters are very distally displaced and a huge wide opening of the external urethral orifice. Along the bottom row, we have images within the urethra. And on the left, you can see that there's two separate ureteral orifices and tunnels right next to each other. And then on the right, we don't have as much fluid distension. You can see that there's one opening at a distal level. And then if you look further down, you can make out that there's another ureteral orifice just right toward the middle of the slide. So again, two that didn't open at the same level. So why does this happen? And I'll be honest with you, I'm not a big lover of embryology, but just as a really quick, kind of concise meat of the bones here, if we think about the development of the urinary and the reproductive tract, they happen at the same time. So unfortunately, if there is a change or a failure in one development, it affects the other structures as well. So the kidney develops from the metanephric blastema. It's a mound of tissue, and it's going to develop in concert with the ureteral bud. So you see in the purple area, which is the mesonephric or Wolffian duct, the ureteral bud is located in a very specific place where it's going to develop. And as it develops, it should reach out and touch that metanephric blastema, the developing kidney. By the ureter hitting the kidney, it actually triggers normal development of a kidney. So it needs to be in a very specific place. So if we think about ectopic ureters, one major theory is that if that ureteral bud is not where it's supposed to be at, say, position A, and is more laterally displaced in the areas of, say, B, C, D, or E, we can see that abnormalities are suddenly going to happen. If it's really laterally displaced out here at E, as it develops, it may not even touch the metanephric blastema, and hence you will not even develop a kidney. You'll end up with renal agenesis. If it develops at, say, C or D, where it's way malpositioned, you may end up with a malformed kidney or developing renal dysplasia. And we see that quite frequently with this disorder. The other problem that we have is that once the ureteral bud hits the kidney and it starts to develop, the formation of the bladder neck and the urethra from the actual type of cloaca is caused by absorption of the common excretory duct, which is this portion between the ureteral bud and the cloaca, starts to absorb and move in. So the further laterally that ureteral bud is displaced, you can see that the migration or absorption of the common excretory duct doesn't allow a migration to the normal anatomical position up at the tip of the trigone. The final issue we have is that once that ureteral bud is hitting the kidney and that absorption starts, part of the movement of those tissue creates the actual trigone and the proximal urethra. And the smooth muscle that aligns in this region is responsible for creating the sphincter mechanism. We know we don't have an anatomical sphincter there. It's a sphincter mechanism. So if there is a malformation that occurs as this tissue is absorbed and the rotation and realignment, we certainly can have a malformation in this region, which will result in a weakened sphincter mechanism competence, and we have hence, some incontinence that can occur. We looked at 25 female dogs with ectopic ureters and mapped out where the ectopic ureteral orifices were located. So we know they should be right up at the tip of the trigone on left and right. But look at how many of them occur still within the bladder, but not in the correct position, right at the bladder urethral junction at the internal sphincter mechanism, or all the way down the distal portion of the urethra. And we see a lot of Labrador and Golden Retrievers here. They do tend to have displaced ureters all the way at the distal end. It is possible that the ureteral orifice may end up directly in the vestibule itself. So hopefully this just gives you a little understanding where if one thing goes wrong, it's very much a cascading effect that can cause other abnormalities. Hence, in our patients, for us to make responsible recommendations for treatment and be able to give reliable outcomes, we need to make sure that we look at both the upper urinary tract as well as the lower urinary tract. And here's a couple of images. So commonly recognized abnormalities associated with ectopic ureters can be related to the kidney itself. And here we've given an IV contrasting agent, Renovist, which is absorbed and filtered through the kidney. And here you see a very nice normal kidney, beautiful blush. And we see a very nice normal ureter, about 3 millimeters. Compare that to the other side, where you can see that we have a dysplastic kidney. It is taking up contrast, so it is functional, but the calyces and the pelvis are dilated. There's less cortex. I'm not quite seeing a ureter on this as well. The picture to the right, we see at the gold arrow that there's no identifiable kidney. So this is a situation of renal agenesis. And then compare that to the other kidney on the right with huge dilation of the ureter, renal pelvis, and you don't really see the nice outline of the cortex. Also notice when ureters become really dilated, they become very tortuous. So puppies are born with this. Those ureters don't dilate as a result of obstruction. They have a congenital abnormality, which we can refer to either as hydro or mega ureter. I've also mentioned a couple of times that it is not uncommon with ectopic ureters to have an associated ureterocele, and that's a cystic dilatation of the terminal portion of the ureter without an actual stricture. And you can see this area down here that is non-contrast enhancing. In our bottom row is a nice depiction of, again, an intravenous urogram, and we see one ureter that is dilated and tortuous. And if you look very carefully, you can see the other ureter, which looks fairly normal, nice and straight, about 3 millimeters. It is important to make sure that your imaging includes all the urinary system. So here we have the kidney and the ureters. We also want to make sure we include the bladder region and where the ureters insert. And finally, on this bottom right slide is a nice depiction. The bladder is full of contrast, but we can see that we have a ureter that's extramural coming right along the edge here on the outside, right alongside the urethra here. So again, lots of abnormalities that can occur associated with the formation of an ectopic ureter. Many of these abnormalities are going to change how you look at this patient and what treatment recommendations you may make. So as a final note, just a quick video giving you real time of what we can see cystoscopically. So again, you see the normal vestibule there, and you saw there was a paramesonephric remnant on this. As we're now in the urethra, you see a very thin, superficial ectopic ureter right here. This would be the left one, and we can see the pathway of it as we go in. This patient's a little bit over distended. We're seeing some cracking of the mucosa here, so we're going to release some of the tension on that. That's why it all falls in on you. And we're going to start to back the scope out, and you'll be able to see that the other displaced ureter, the other ectopic ureter is right here. The base of that septum is quite a bit thicker and deeper, and it's a really large ureter. So this dog has two ectopic ureters. One is more proximal, one is very distal. So again, we need to think about these things as we want to move forward and continue our goals of being able to make the best choices for our patients. And I thank you very much for your time. And